I've been thinking how to approach this session. And the reason I've been asked to do this session is because of my work on maternity experience with Jill Phillips. Whose Shoes? The board game that enables us to think about lived experience from all different viewpoints. So that of the pregnant women using our service, but also that of the staff working in a service. Whilst I was pondering how to run this event, I suddenly realised it's obvious I should do an episode of my podcast. I know how to do that. It's easy. And I can record it, and it will be of interest to people other than obstetric trainees, I hope. But it will also help you perhaps to understand what those leaders, what those consultant obstetricians are tackling day in, day out. So coming back to my question, what matters to you? It's quite a simple question, really, but one we can forget to ask. The What Matters to You is a campaign in Scotland, and we've recently passed, on the 9th of June, What Matters to You Day. This is a campaign and an annual day encouraging healthcare professionals to think about asking what is important to people. This establishes a relationship between those giving and those receiving care, and immediately helps you to understand the person in the context of their own life and the things that are important to them. I remember some years ago reading a book by Atwell Gandhi, Being Mortal, which was about end-of-life care and how we look after people towards the end of their lives. And end-of-life care can focus the mind a bit. What are the things that are really important to you? Is it staying at home? Is it attending a certain family event, such as a wedding? Is it being able to eat and enjoy your food? Is it being able to retain your mobility? There are many different options, and for each individual person, what's important to them, what their priority is, will be different. So with this crucial insight, you're in a much better position to work with the person to find the best way forward for them. And maternity care is no exception to this. In maternity and pregnancy care, what is important to that woman, to that family, to that new baby? I had a look at the What Matters to You website, and I would urge you to do the same. There's a multitude of really useful resources, partly for professionals in how to have an open conversation and really give people an opportunity to say what is important to them and express their feelings about different options and how that might impact on them. But also for patients or pregnant women, there are a range of resources that can help you think about how you ask your questions and how you can advocate for yourself and the things that are important for you when you're in a situation with a healthcare professional and you perhaps feel you're not getting the support and advice that you need for the context you're interested in. Looking at the website, it also talks about levels of listening, and there's a great resource on the website, which is a short video about levels of listening. It can sound a bit stupid to ask if we're listening when we're having a conversation. Of course we are. But are we? Even if we're trying our best, sometimes we just aren't, and I find this myself. Sometimes on a ward round, a midwife is patiently presenting the information about the woman she's caring for. I think I'm listening. There may be distractions and other sounds, or I'm perhaps thinking about the woman we just left, and then I realise that I've zoned out and I haven't heard a word. In some ways, that's okay. I'm conscious that I haven't concentrated. I can politely, but rather embarrassedly, apologise and ask for the information to be repeated. But sometimes it's worse than that. I believe I'm listening. I believe I'm giving my full attention. But then I might ask a question which demonstrates that I'm not really properly listening, that I've missed some information. And that is more problematic. I may have missed a really important piece of information without even realising I have. So let's think about these levels of listening. Level 1, listening from habit. You're essentially downloading information, and you have a habit of reconfirming your opinion and judgments. So you might ask a question and expect a certain answer. Even if the person gives a different answer or unexpected response, you may adapt that. You reconfirm what your existing opinion is. Listening level 2 is from the outside. It's factual. You're noticing differences between what you're hearing and what you thought you might hear. So you're disconfirming. You're using new data. Your mind is open. Listening level 3 is listening from within. It's empathetic. You're establishing an emotional connection with a person. Your heart is open and you're seeing things through the other person's eyes. You're seeing their perspective. And then listening 4 is listening from a source. It's generative. So from the listening, seeing the future differently, you're connecting to an emerging shift in identity or ideas. I think these levels of listening are very interesting, and I would like to think that most of the time when I'm with a woman, I'm at least listening on level 3. Empathetic listening, seeing things from her perspective. And when I attend our Maternity Voice partnership, I would hope that I would be listening at level 4. My heart and mind are open. I'm thinking of new ideas. It's sparking things in my brain. It's giving me a different future, different outcome from if I had sat and done something on my own. And in my mind, this is where the work I do with Whose Shoes and the board game come into play. The lived experience scenarios and poems can help me move directly to level 3 and level 4, deeper listening, taking me straight to seeing the world through another's eyes, shifting my thinking, and having those so-called light bulb moments when I realise that actually the future needs to be different. I need to do something quite dramatically outside my comfort zone. So the What Matters to You initiative is important to help healthcare professionals understand what's important to their patients, in our case, pregnant women and their families. But we can also apply these levels of listening to ourselves and to staff. So I'm now going to take a bit of time to think what matters to you, the labour ward obstetrician or labour ward lead. It can be overwhelming being the obstetrician on the labour ward. Some of you may be familiar with Gilbert and Sullivan. There's a fantastic song, The Modern Major General. And I'd urge you to take a look at the lyrics or play the song on YouTube if you have a moment. In essence, it lists the huge number of facts the Major General is expected to have, the skills and experience they should have at their fingertips, the immense responsibility and breadth of knowledge and ability that they are supposed to display. And I think being a modern obstetrician can sometimes feel like this. We can be pulled in all directions, multitasking. We have enormous responsibility, not only day to day on that shift, but longer term. There are huge expectations that we will get everything right all the time. We won't make mistakes. And in my mind, I have a vision of us surrounded by plates spinning, and all the time a fear of one smashing, falling to the ground, and then the whole thing tumbling down around our ears. So I'm going to pause and think what matters to you as the labour ward consultant. Share some ideas about how to make it more manageable. I recognise that no one size fits all, but I can tell you what has worked for me over the years in my role, first as labour ward lead and now as a labour ward consultant. One of the key aspects of the job is leadership and multidisciplinary team working. This is important. You need to lead by example. Role model how you want people to be. That can be easier said than done. We all know how we should behave day to day, but actually, can we try and do our best day in, day out when we're under pressure? It's not always easy. We're working, teaching all the time, not just formal sessions, but on a shift, teaching and supervising junior doctors, specialty trainees, but also junior midwifery staff. Anything we do, they may copy and emulate, or they may discount it and say, that's not actually how I want to be. So the negative is as important as the positive. And with this leadership comes a big weight of responsibility. Sometimes in medicine, I think we can be a little narrow-minded. And one of the things I've done is try to open my mind, try and look up and out. There are many, many books and articles and podcasts and TED Talks on leadership styles. Think about the people that were leading when you were training, or the people that you felt, I want to be like that when I qualify. But also think about the people you don't want to be like, and what were they like? What is it about their behaviour, or the way they taught, or the way they practiced, whether that's midwifery or obstetrics? What put you off? And if you're reading all these ideas and thinking, share things around. I created a little maternity library in my unit. I put some books with a sticker on in the staff room and left them. And I know they've been handed around the midwives year after year. I can't tell you if they're there now, but I know every now and again someone pops up and tells me something about a book they've read that had my name on it. So share the ideas, what you're reading and what you're thinking and what you find relevant with other members of the team. Know that even though you are a leader, you're never on your own. Don't be frightened to phone a friend. Use your colleagues. They might be midwifery, they might be anaesthetic, they might be paediatric, there may be other consultants within your team. Remember that teamwork is essential. Use those relationships, forge those relationships, and understand the other members of the team. What are their roles and responsibilities? At my work, we've done a series of job shadowing or work buddying. Our home birth team leader shadowed our labour ward lead obstetrician for a shift. It gives insight into what your role is to the person shadowing you, as well as insight from you into what their role is. Most recently, I went and shadowed one of the staff in our maternity admin office to see what they had to do to ensure that bookings, scans, clinic appointments happened at the right gestation within pregnancy, and how they ensured that they were booked with the right midwife to make sure there was continuity of care. My consultant group are immensely strong. We support one another. It's never a bad thing to phone another consultant when they're not on call and get them to come in and give you a hand, give you a second opinion, fresh eyes, fresh brain, fresh thoughts. So even when you're that labour ward consultant, you're not on your own. Midwifery management colleagues or professional midwifery advocates are also your allies. Sometimes when something can get a bit overwhelming, it's great to just sit down, have a cup of tea, take a break and think, how can you manage this better together? Another aspect of being a labour ward lead obstetrician is that of guidelines and implementation of guidelines. We can be bamboozled by new nice guidance, RCOG green top guidance, or NHS England guidance, long-term plan guidance, Ockenden report guidance. There's a never-ending stream of things we need to examine and check. Are we up to scratch? Are we doing the right quality? And for this, I would say, use your external networks. Stop reinventing the wheel. We're doing the same up and down the country. Use BICS, the British Intrapartum Care Society, or the RCOG, or your local maternity system networks, or your regional clinical networks. These are all formal examples of networks, but what about informal? If you look at the hashtag MatX, there are many obstetricians and midwives sharing ideas on Twitter, Instagram, Facebook. Another idea of sharing ideas more widely is randomised coffee trials. Can you have a cup of coffee with someone, either on the phone or via Zoom or Teams? Can you spare an hour or half an hour to talk to someone working perhaps in a different area of the country, or perhaps even in another country, working on the same stuff? Share ideas. That will take you to listening level 4. You'll be opening your mind. You'll be thinking differently. It can be very beneficial. Most people can spare half an hour, and actually, through the pandemic, because of the virtual ease of meetings and the acceptance of virtual attendance at meetings, we can actually network better with people in other areas than we could ever before. Using our clinical networks to optimise care, such as neonatal in utero transfers, making sure that preterm babies are born in the right place, in the right hospital, in the tertiary centre, the place where they need to be, can make a big difference to the outcomes, long term, the health of that baby and that mother. Guidelines and implementation of guidance can be very dry, can be very boring for those of us that don't necessarily like that sort of thing. Use a bit of a creative streak. Long ago, when I was the labour ward lead and actually the clinical director for maternity, we were trying to pass our CNST level 2 and level 3. I wrote a series of unit emails sent to the whole maternity unit with popular themes such as London Fashion Week, the 2012 Olympics, popular TV shows such as Downton Abbey or the latest Bond film. I tried to appeal to people, make it a bit more interesting than that just global email that gets deleted straight into the bin. It catches people's attention, makes them more interested in what you're doing and more motivated. Think creatively. What could you do? What are your strengths? Do you like to write? One of the things doing Whose Shoes has got me to do is to blog, to record videos perhaps, and now podcast. It's so simple for you to be able to record, edit and do something yourself. What might catch people's attention? what might make things more attractive to people to get involved? And what skills do you have in your team that you could utilise? Next responsibility for most labour ward obstetricians is quality improvement, improving the data outcomes, trying to do something about the caesarean rate maybe, or the postpartum hemorrhage rate, or the number of bad tears that women have experienced. How can we tackle that?
Sally Jane challenged us to do a rap
to tell you about MatX
and put it on the map.
Mums are here to help lend a hand,
to tell you how we feel and help you understand.
We do stuff together, we get things done.
Come and join us, MatX is fun.
In my experience, women are the hidden weapon to drive change. If women start asking for stuff, then that gradually gets staff on board. I've tried this during a caesarean when I was trying to implement optimal cord clamping, or at least a delay of some type to stop immediate cord clamping. I started telling women in the antenatal clinic that this was possible at caesarean, and then gradually women started asking for it. And I also told women that if someone told them they couldn't have it, that they could say, Florence said it's possible. Florence said it could be done. So to drive a change, get women involved. They can see our blind spots. They can help us. If women demand something, then it's difficult for staff to maintain the reluctance to comply. Get involved in your Maternity Voice partnership. Any obstetrician who wants to run a quality improvement project should start there. And at least one of the obstetricians in your unit should have in their job plan to be part of the MVP. But you can also encourage specialty trainee obstetricians and gynecologists to attend the MVP and start there when they're starting with any quality improvement they want to do. If you start there, you won't waste time and energy doing something that's irrelevant, or introducing something that when you evaluate, it simply hasn't done what you expected. Co-production from the beginning. It's not simply a buzzword, it's the way forward. And have you done the 15 steps? This is a fantastic tool you can use with your MVP to walk round the maternity unit and see it in their eyes. Not how you see it, not how you walk past day after day the same stuff without noticing it, but the way a woman will see it, or a birth partner will see it on arrival. What are the things that they will notice that can be changed? And what about rewards? Over the time with MatX, we've done a whole variety of rewards, and it's amazing how a simple, small, cheap token can make people do stuff. When people are pledging at the end of a workshop, if they think they're going to get a miniature crock or a badge or a sash, they'll go for it. They'll be much more enthusiastic. We're like kids in that way. So we've used stickers, badges, sashes, shoes, all sorts of rewards to encourage action, to encourage people to make a change. And that little token that will often remind people later on to go back and do or complete whatever it was that they said they might do. These rewards accentuate the positive, make people happy, make people more willing, and draw other people in. Where did you get that badge or shoe? How do I get one? What did you do? It starts a conversation. there's a ripple effect straight away from what could seem quite a trivial resource. And rewards don't stop at staff. What about Stop and Celebrate, a fantastic campaign run to stop every time a woman is leaving the labour ward, to celebrate, congratulate her on the birth of her baby. It's a small thing. For us, it's day to day. For her, it's the birth of a new life. It might be her first baby in the beginning of her life as a family, or it may be she's taking that baby home to her siblings. She's done the best she absolutely can. It's celebrating that little moment, that major milestone in her life and that of her baby. We can spare a few seconds to stop what we're doing, turn round and celebrate with her, surely. Another responsibility that falls at the door of the labour ward lead is training. And I would say for this, you need a carrot, not a stick. It's no good telling people again and again that they must do their training. You need to make stuff fun. Food is an obvious draw. Breakfast meetings with pastries or cake or fruit. One time I just put a load of stuff on a trolley and wheeled it round, drawing people in because they wanted the strawberries that were on the bottom. And making it fun can also be doing things like the Lithotomy challenge. What does it feel like to be in lithotomy? What does it feel like to be on the operating table? What does it feel like to be on the anaesthetic side of the drape in theatre? What does it feel like when you swap jobs and you go and work in the admin office or as a midwifery support worker? Switching jobs, role-playing, they give you a laugh, but they are serious in affecting change. We try ever more inventive scenarios for our prompt training. I've recently recorded a cord prolapse scenario with the help of one of our midwives with a prosthetic bump. She even made a pair of tights with a balloon inside so that we could attempt to fill the bladder in simulation to lift the presenting part off the umbilical cord. Be inventive, be dramatic. It makes it far more interesting. People are much more likely to remember your teaching and training if it was fun, if it surprised them. It's going to stick in their minds. Try and involve more people. We've got a whole team who run our training. The practice development midwives, yes, and a number of obstetricians, but also we can drag in an anaesthetist, a paediatrician, can have a bit of a laugh. In our cord prolapse video, one of my anaesthetic colleagues did a fantastic simulation of a spinal, so much so that I even thought she might stick the midwife in the back with the spinal needle. She's now going to remember forever in her career cord prolapse. What are the important things? Because she's going to remember that day where she acted. Don't be afraid as a leader to take risks. Who dares wins. Don't be afraid to break the rules, experiment and try. Some of you may have heard of Jenny the midwife. Jenny's retired now, but she was absolutely phenomenal. She felt that skin to skin in theatre was really important at a time when not many midwives realised that. Jenny got so frustrated with the baby not being skin to skin in theatre that she took a ladder and wrote on the wall of the operating theatre, "Is the baby skin to skin?" And I'm not advocating that you go off and deface a number of walls in NHS organisations. Please don't. But she did change the status quo. In the end, the whiteboard in her theatre has a box for "Is the baby in skin to skin?" as part of the checklist. So some brave people with courage can help us all by pushing practice forward. It's okay to experiment. Try something, and if it doesn't work, try something else. Over the time I've been a consultant, I've been trying to work on the number of women feeling well supported to have a vaginal birth after caesarean. I've gone through a number of models of consultant midwife, specialist midwife, then a workshop style event, and now a continuity of care team. It's okay to try stuff out and evolve it. You don't have to have the answer right at the beginning. You can modify, try, change things, retry. It's okay to be flexible and to accept also if something doesn't work. Never mind, we've learnt from that. Let's try something different. I mentioned the modern Major General and the modern obstetrician bamboozled with the CQC, CNST, endless maternity surveys, training, MAT-NEO-QI, the long-term plan. The list is endless. But at the end of the day, ask the consultant, ask the obstetrician. One of the most important components is well-being. You can't hope to care for other people unless you care for yourself. So what matters to you, whether that is all the different things I've listed, or whether that is your actual well-being, you need to start with your well-being first. Balance is important as a labour ward lead. You need to pace yourself. Don't try and do everything all at once. Don't try and do too much too quickly. Make it manageable. And if you try and change too much all at once, it'll be too much for your team too, let alone for yourself. So you need to balance what you're doing, break it into manageable chunks, and also make sure that work isn't the be-all and end-all of your life, that you've got other things, whether that be hobbies, your family, friends, days off. What are your strategies? Wellbeing's a bit of a buzzword. I don't actually like it, the kind of tokenistic wellbeing sessions that are being run at many hospitals up and down the country. But caring for yourself, that is really important. I walk my dog. I often do a yoga video when I get home from work. A little bit of stretching, relaxation and breathing does a lot to set me right. So as you're the modern obstetrician on the labour ward with so many calls on your time and so many demands on your expertise, make sure that you think about what matters to you as well as what matters to everyone else. Now, in my podcast, I always have a zesty bit. That's the essence of what I want you to remember at the end of the day. What would my zesty bit be from this episode? I think it has to be, what level of listening are you using? Not only for the women using your service and the families that you see day in, day out, but also for your fellow staff. Are you really listening? Are you really imagining the world from their viewpoint? Are you asking what matters to them and thinking how you might prioritise those things? What changes you could make that will be most meaningful? And when you listen to women, are you really understanding what matters to them? And last but not least, do you understand what matters to you? As you move through your career as an obstetrician, it's taken me time to understand what's important to me. Yes, the day-to-day is. Yes, the birth of babies is amazing and extremely rewarding. But I know that I need a bit of creativity. I need something outside the job. Hence the fact I started a podcast. So understanding what matters to you yourself so that you can get the right balance at work, so that you can sustain yourself as a consultant obstetrician and lead people effectively on the labour ward is very important. For the rest of today's session, we're going to look at a small number of cards from the Whose Shoes board game together, which I'm hoping will prompt a little bit of thought. It's a bit difficult running this session because I can't have that much interaction with you. Normally at a Whose Shoes workshop, we would sit down in multidisciplinary groups with plenty of women and families that have used our service, hopefully lots of babies present, and we'd spend 2 or 3 hours having discussions prompted by scenario cards and poems. People would write down on post-its their ideas and thoughts about solutions to problems, what they might improve to make things better. And at the end of the workshop, we would ask people to pledge what they might do differently as a result of the day. The workshops are energetic, buzzing, exciting, and above all, fun. So I'm going to show you a short video which hopefully captures the feeling of what it's like to be at one of these events.
Other babies are choosing to
And that's where the teamwork comes in. Speak up when I think positive change can be made.
The board game works with different views from different perspectives. Blue are women and families. Yellow are frontline staff. Red are commissioners, managers. And green are charities, third sector, perhaps antenatal classes. I've chosen a single card from each of those categories, which I'm going to read and which we can think about together. Hopefully these will help you get into that level 3 listening, imagining you're in that person's shoes and imagining what you, as the labour ward obstetrician, could take away and think about. I'm going to start with green. Home birth. It's all very well saying that women are being offered choice, but this depends far too much on how people's choices are described to people. It's all very well saying women are being offered choice, but this depends far too much on how choices are described to people. Mums are not normally ill, so why should they go to hospital? Birth is a natural event. Perhaps home birth should be the norm rather than the exception. I'm hoping that this card will make you think a bit about home birth. We know from the birthplace study there is a large amount of evidence that suggests for multiparous women having their second or subsequent baby in a developed health economy that home birth is actually the safest option for that woman and has no significant difference in outcomes for the baby. I like this card because it works with the idea that home birth should be the norm rather than the exception, which flips on its head what currently is happening. At the moment, if you're going to have a home birth, you opt into home birth. But could we think about it differently? Could we reimagine it and think you have to opt in to hospital birth? What would that look like? What would that do to our services? And if you don't want to be as radical as that, you should at least think as an obstetrician how you're going to support home birth. Home birth needs a home birth team, but it also needs partnership with obstetricians. When things do start to deviate from the normal and a woman needs transfer into hospital, she needs timely review by obstetricians, often in an emergency situation. Having good working relationships and clear guidelines for the home birth team to operate within and to work together and to perhaps simulate some of those skills drills in a home situation is essential to improving and increasing the home birth rate. So I've included this card because I would like you to think and question, what are you doing with your home birth team? Do you know your home birth team? Have you been out with your home birth team? Do you know what their practice is like? Do you know what their transfer rates are? Do you know if they feel well supported by the obstetricians in your unit? Do you have a designated home birth lead obstetrician? And what could you do in your practice that would help women that are uncomplicated, that don't have risk factors, understand that perhaps home birth is the safest option for them and safer than coming in to our hospital? The next card is blue. Ward rounds. When I was in labour, the consultant walked into the room with a whole crowd of people to check how I was doing. I know they were all there to help, and students have to learn, but I felt surrounded and it was really intimidating. This card is important because a ward round is something we take for granted. We go in, we want to meet the woman, we want to put a name to the face, we want to understand the story we've heard at handover and talk to that woman. But we're interrupting her labour. So we need to think about strategies. Do we all need to go into every room? Could we delegate, have a conversation, some of us, but only some of us go into the room? But that's talking about a woman without her, which also doesn't feel right. We could ask the woman what she feels. Would she like the ward round to come in or not, and give her a choice? Would she like to meet the doctors as a matter of routine? Are there some rooms on the ward round that you perhaps don't need to go into? If things are uncomplicated and the woman's labour is progressing, could you leave that woman out of the ward round? Do you warn the woman that you're coming in on the ward round? And do you give her a choice about how many people come in, whether it's just one person or whether it's a whole crowd? How do you introduce yourself when you come in on the ward round? I try and get the woman's name right so that I can come in and say, hello, Rachel, for example, my name's Florence, so that it's really clear that this is about her and that I know who she is and I'm treating her as an individual, as a person, by name. Who's on your ward round? Do you have your anaesthetic team come on your ward round? We do, and that can be very helpful when you're reviewing a woman perhaps with severe preeclampsia, or who might be considering an epidural, or a woman who already has an existing epidural to check it's working effectively. That also might mean in an emergency situation she's met the members of the anaesthetic team. But giving a ward round some thought and not just doing a ward round for the sake of doing a ward round, ticking that CNST box that the consultant has been round and reviewed everybody, thinking of the purpose of the ward round and how that ward round impacts on the woman is really important. Rather than doing the ward round at your shift change or 8 o'clock when you come on, could you do it at a time that works for the woman? Perhaps she's having an examination at 10 o'clock and she's sleeping at 8. Could we leave her to sleep and see her when she's awake at a later point? Or at a point when a decision actually needs to be made about her plan of care? So understanding and being less rigid about our ward rounds and thinking a little bit outside the box for our ward rounds, I think is a really important topic. Red. Patient stories. Everyone is now obsessed with collecting patient stories. In a way, that's the easy bit. How do we show our patients that by sharing their story, they made a real difference? Some of you may have heard of "you said, we did" as a way of demonstrating patient feedback being taken into action. And in the MatX community, we've slightly changed that in that we've got some badges that say, "I said, I did." Because if you're truly doing co-production, then the women who are giving you the feedback can also be part of the solution and can help you implement change. But that idea of "you said" or "I said," "we did" or "I did" is key. Patient feedback is no good if it's not used to make action. And there are lots of innovative ways you can use your feedback. Most of you will know from the friends and family test, there's a lot of useful feedback in the free text. Can you make a word cloud out of what people have given in terms of feedback? Can you display your thank you cards or feedback on feedback boards on the wards? Can you encourage people to give feedback through social media channels, your trust website, or your local maternity voice partnership? Encouraging feedback, but then making sure that the feedback goes somewhere meaningful is really helpful. It's really essential. So we have some boards up on our wards that give the most recent feedback, but also then says what we've implemented as a result. For example, we had a lot of feedback about women feeling on their own in the early stages of labour or induction, and we implemented the fact that partners could stay with those women as a result, giving their birth partner much more support in those early stages. It was a win-win. The women feel better supported, and the staff feel they've got additional people there helping them support those women. We have a chalkboard at the entrance to our maternity unit and on one of our postnatal wards, a maternity graffiti board, which was the idea of one of our midwives at our first ever MatX workshop at Kingston Hospital. People write their feedback, but people also write their birth announcements. And when siblings were allowed to come to the unit, they used to grab the chalk and draw little pictures and welcome their baby brother or sister to the world. So there are lots of innovative ideas about how we could use feedback and make sure that those patient stories and feedback count for something. So have a think about how you are using feedback from pregnant women and families in your unit, and what creative ways you might display or use it, and in what way it might spark action. Finally, your yellow card. Letting everyone down. Some days are impossible. We simply do not have the staff or equipment we need. While I'm dealing with people complaining about waiting for beds on the antenatal ward, the next lot of problems build up. Meanwhile, midwives on labour ward are asking for more staff. Then I go to meetings where I haven't done something I said I'd do, and I'm confronted with unhappy colleagues. This card really rings true to me. This is what the day-to-day can be like. Some days you just don't feel like you've got enough staff to make ends meet. You've got women getting frustrated and upset because there are delays in being admitted, and you've got staff that are feeling stretched and under pressure. So I included this card because I think a lot of what I've said today, you might think, well, that's all very well. That's really nice. That's great. Florence can do that. But the reality is I couldn't do that in my unit. Well, the answer is you can. You have to pick your time. You have to pick your moment. You have to do it when you feel energised and able to. But you will find those moments. And don't be over ambitious. Start with something small. For example, on that card, there could be several people, such as your midwifery manager or your PMA, who could help talk to people, talk to the staff, or deal with the bed situation. It doesn't all have to be down to you. Use the rest of the team. And if it's all getting too much for you, actually maybe go into the office, sit down, have a cup of tea, take a breather for 5 minutes, and then come out and deal with the bedlam that's going on outside. That's okay too. So, yes, the reality is it's a very demanding role, but actually it is manageable if you divide it up and break it down into small pieces. Many hands make light work. I'm going to end the session with a poem. A very important meeting. The staff are all busy, rushing about. Room 3 is pushing. I hear someone shout. A midwife rushes in. Her presence is fleeting. She mutters something about going to a meeting. A meeting! I put my arms round my wife, contemplating, anticipating the most important meeting of my life. I chose to end with this poem because at the end of the day, this is what it's all about. It's about birth. It's about a new person entering the world, meeting their parents for the first time, and creating those parents and new families. Sometimes we need a little reminder that our day-to-day is made up of these profound, precious moments. I hope you found this an interesting session. I've put some links in the chat, and I'm going to ask the college to share those links with you after today's event so that you can follow up on some of the topics I've talked about. Many maternity units up and down the UK have the Whose Shoes card set and board game, and now that the pandemic is hopefully on the wane, it's time to get out those cards, think about them with your teams, and start some of this more creative work, re-energising ourselves and those we work with, and getting back to what matters to you, but also what matters to us. Thank you very much. I hope you found that an enjoyable and entertaining session. And do please have a listen to some of my other podcast episodes. The Obs Pod can be found on Apple, Spotify, and any of the major podcast platforms.